Let's get 2 minutes on the clock and your time starts now. Case 3. Kelly McHale is a 20-year-old female attending your GP clinic asking about options for contraception. She started her first sexual relationship and is keen to avoid pregnancy with upcoming travel plans around Australia for several months. She has a significant medical history of migraines with aura and has a severe needle phobia. She states her parents have strong religious beliefs and she doesn't want the implant on as she worries they'll see the scar on her arm. She takes no regular medications and has no allergies. She has no significant family medical history. Her vital signs are a blood pressure of 120/80, pulse of 75 and a BMI of 24. Question 3.1. What contraception options would be suitable for Kelly? List 3 contraception options. Alright, time is up and let's get to some answers here. So, we have the levonorgestrel intrauterine device, or the Mirena uterine device, or the Kylena uterine device. They're all going to be lumped together into the one thing, and in this setting in particular is probably the most appropriate one for her, so it's going to get you 3 marks off the bat. The next option here would be something like the progesterone-only pill, be getting you 2 marks here, or condoms being the least reliable method of these ones here, being 1 mark. For those that would promote things like abstinence, would not be worth marks here given the pure unreliability of it, particularly in a setting where you have someone in a new first sexual relationship. Good luck saying, oh no, put the brakes on. I think realistically we have to prepare our patients better than that to say, look, life happens, but let's make sure that life doesn't happen, if you know what I mean. Hopefully that makes sense. We do have some answers coming in from chat here. So we've got Mirena IUD, fantastic. Again, just making sure that you don't specify any abbreviations here. Copper AD, oh yes, sorry, that should definitely be on here. Absolutely fantastic, well done. Yeah, Copper AD here would also be worth 3 marks. And progesterone-only pill, fantastic. We have condom, Slender, so Slender being one of the progesterone-only pills, a fantastic option there, and Mirena as well. All right, so fantastic work, guys. Let's get to question 2. So, 2 minutes on the clock, and your time starts now. Question 3.2. She states she's had penetrative vaginal intercourse with her partner, who states he has had no other sexual contacts. You discuss the importance of screening prior to commencing contraception. What screening would be appropriate for Kelly? Provide 4 specific screening tests. All right, so time is up. Let's get to some answers here. So before we're talking about contraception, we know that she's been recently sexually active. We need to make sure she's not actually pregnant. So one of the first things you should be considering, and this is that old adage that any female of reproductive age is pregnant until proven otherwise. Urine pregnancy test, 2 marks straight away. Now, if we look at our STI guidelines, then we should be considering for an asymptomatic patient. They haven't mentioned any symptoms here, and so we would presume they're asymptomatic. We would be looking at HIV serology, syphilis serology, gonorrhea urethral first pass urine, or self-collected vaginal swab nucleic acid amplification test. You could put polymerase chain reaction as well as PCR, the same thing, or a chlamydia urethral first pass urine, self-collected vaginal swab nucleic acid amplification test, another mark in there. We do have answers in from the chat here. So we've got chlamydia PCR, gonorrhea PCR, fantastic. Just remember, try and avoid those abbreviations as much as you can. And here we have urine pregnancy test, urine chlamydia PCR, urine gonorrhea PCR, HIV. Brilliant, brilliant, brilliant. We have seen a massive resurgence of syphilis in Australia in recent years, which is why one of the recommendations from STI guidelines at the moment is that all routine testing for STIs should include HIV and syphilis serology. Man, I've said it before, I never thought in my career I would be managing patients with syphilis, but I've had to do it several times because of this resurgence. People will do what people will do. What can I say? Stay safe out there. Of course, we have a third question here, so let's get 2 minutes on the clock and your time starts now. Question 3.3. Kelly has a Mirena inserted without complication, but she returns 18 months later and states things have gone wonderfully well and she's keen to begin her family. You discuss preconception counselling and organise removal of her Mirena. Discuss the steps involved in removing a Mirena. Provide 3 steps. All right, time is up. Let's get to those answers. Now, the first step here is going to be obtain patient consent. Really, really important. This can be verbal or written, preferably written, but verbal, if you get that, you can write it down in the notes and that is just as legally sound. Next thing would be to consider chaperone for procedure. It used to be kind of left to clinician judgment. These days, I think there really is a push that wherever possible, have a chaperone there. Just cover yourself to make sure that everything's above board, everyone's happy, and of course have that discussion with the patient as well. This is a invasive procedure, but we should be using sterile gloves for this procedure. It's a really, really simple one. Insert the speculum to visualize the removal strings and pull with gentle traction on the threads with forceps. So each of those ones going to get you a mark there. Really, really simple. Now, for the insertion of Myrena, you should have particular training for that, and preferably, even though there's no actual number of required supervised insertions before you have independent practice required, it is good to pair up with someone that does do it regularly to make sure your technique is good in actual patients as well before moving to independent practice there. I think that is something that you do need that training to be able to do safely and consistently. I think that removal of Myrena, though, is pretty much fair game for any GP in Australia. It should be something that we know how to do, and I think if we're saying that we're practicing as consultant-level practitioners, then I think this is definitely going to be fair game on the exam as well. Now, we have here, of course, obtaining informed consent, offering a female nurse chaperone. Yep, correct. It doesn't, preferably female in a lot of cases, but I think as long as you specify chaperone, I think you're going to be covered. And of course, documentation of procedure. Yes, yeah, I think that's actually really, really important as well. Not on this list here, but I think that probably the tricky part with that one there, I guess, is that here they've asked about. You've got me. You've got me. We're reading the question being asked. So here we are discussing the steps involved in removing a Myrena. I mean, obtaining patient consent is in there, so I think it would follow logically then that documentation of procedure would be in there as well. So yes, I'm going to give you marks there. Well done. Now here we have a comment. I hate these types of questions. Of course I'm going to get consent, but it's not something I would ever think to write down as part of the process. Yep. For these types of questions, ask yourself, kind of, as stupid as it is, the patient's in front of me, what am I actually going to be doing? What am I actually doing in real life? And all those stupid little things, they're free marks. Now, if you've got lots of other things in there, again, they've asked for 3 steps here, and there's a lot more than 3 steps in the option list, and that's always going to be the case. Don't feel like they're trying to trick you or trap you. It's really just making sure that you have an understanding and approach to responding to these kinds of things.